Dr. Madoc, in the real world, patient will fail R-CHOP, they will locally get rice or something, and they come to see you, they have not done well. So if you have obviously access to a CAR T, you're going to try to do this, but what else would you do in that situation?
Yeah, so I mean, if they have access to CAR T and they're a candidate for that, that's an approved setting. If they're not a candidate for that, in the last 6 months we've seen the approval of the BR Pola regimen, so that would be an option. Other things to consider outside of a clinical trial, of course, would be considering novel agents like ibrutinib and a non-GC type or lenalidomide or one of those agents.
Nathan, you want to comment on the Pola durability, the Pola for our audience, and combination with instant combination with bendamustine?
So this was a very interesting study that was presented by Lori Sen, where it was a randomized phase 2 trial that enrolled 2 groups of people, follicular lymphoma patients and large cell lymphoma patients. And in both of those groups, and they both had relapsed disease, and both of these groups were transplant ineligible. And what they did was randomize patients to bendamustine rituximab versus bendamustine rituximab plus polatuzumab. And interestingly, in a fairly small phase 2 trial, 40 patients on each arm, they saw both a benefit in progression-free survival and overall survival with the addition of polatuzumab. And because of that survival, especially the overall survival benefit, it resulted in FDA approval. And if you look at the PFS, I want to say it was nearly triple PFS. Again, not great. These patients were still relapsing, but your PFS went from 2 months to about 7 to 8 months with the addition of polatuzumab.
So we are, obviously there's a Polaric study that is trying to take advantage to bring this in a frontline setting. This study is enrolling, right? This is not completed.
I think that it's near completion, and we will hopefully see the results at an upcoming meeting.
Another study of R-CHOP plus X, trying to improve the outcome. So this is, it's interesting because we are trying to bring the novel therapy, but I think there was an interesting paper presented at Lugano, and there will be an update at ASH from Westin and MD Anderson looking at the R-square ibrutinib in a frontline setting in a patient with large cell lymphoma that are not great candidate for chemotherapy, or just as a window trial, and the response rate is very high. The CR rate is also not, is relatively impressive just for biological therapy, and with a shorter version of chemotherapy. Greg, what do you think?
I think it's a very interesting strategy because with the targeted agents and the antibody, you can actually have quite a bit of responses. In this study, everybody still received chemotherapy if they were candidates for additional chemotherapy. But overall, in this high-risk population, which Jason presented, the results were actually better than expected, typically in those high IPI patients. Now, will we be successful in the future or not will depend a little bit what's going to happen with the chemotherapy later on. We can imagine that if somebody was to develop full chemo-free regimen and was actually resulting in the cures and disappearance of chemotherapy, we would probably all be happy that this is something which would develop. Having said so, so far the evidence suggests that the cures are achievable mainly with chemotherapy, and there's very limited evidence that targeted agents can actually cure patients at this point. But this is definitely something to watch. I know Jason is planning on next subset of study when they will be extending the duration of targeted therapy and try to limit chemotherapy with very careful monitoring of those patients. Additional benefit of this strategy is also that some patients can be quite sicker when they present, and there will be high risk for initiation of chemotherapy. So this targeted therapy could be like a bridging or stabilization before you actually start chemotherapy. Maybe they can actually tolerate chemotherapy later on better. So interesting strategy, but I think...
I have used it in some older patient and had aggressive ABC presentation, and then that allows us to reduce the chemotherapy. That's an interesting thing we didn't mention when we were talking about frontline. The German studies have typically included a pre-phase treatment, Rituxan steroids and a little bit of vincristine. This is actually kind of working really well because patients tolerate easily and they come on day 8 and they're kind of ready to get chemotherapy. So this is something that might be practical to our audience.